Kia ora, my name's Margie Olds, and this is the Glenohumeral Gurus podcast. This is a podcast for clinicians interested in shoulder rehabilitation. I'm a shoulder therapist based in Auckland, New Zealand, and in this podcast I interview clinicians and researchers across the globe about their research and their clinical practice on how we can improve outcomes for people with shoulder pathologies. The aim is to learn, laugh, and try to work out how we can help people with shoulder problems. Enjoy the podcast. This episode is brought to you by Flawless Motion, shoulder braces for people with shoulder instability in male, female, and bilateral versions. So check out flawlessmotion.com or now flawlessmotion.co.uk for your shoulder brace requirements. Right, on with the podcast. Hey, today it's my great pleasure to welcome Fabrizio Brindisino to the Glenohumeral Gurus podcast. Fabrizio, welcome. It's so nice to have with you and connect with you. Welcome.
Hi, Margie. Hi, Margie.
So it's so great to have you join us for this webinar about our frozen shoulder series. And I started looking, I knew you were researching in this space, but I started looking through all the papers you have done, and you've been so busy. So it's great to have you on this podcast to share with us what you know. Could you start by introducing yourself to the audience for those people that don't know you? Tell us about your physio journey and how you got to be where you are now.
Okay. So first of all, thank you for inviting me. For me, is a great pleasure to talk with you in this podcast. And I am a physio based in Italy, in the south of Italy, and I am a clinician on load to research. So I have my private practice in Lecce,
Yes.
and I work with musculoskeletal patients, especially with shoulder disorders. Post-surgical rehabilitation or conservative rehabilitation is the same. I am pretty focused on about frozen shoulder from 2019, and I try to enrich the evidence, to enrich the literature with my works.
Yeah, it sounds wonderful. And you've been doing so. We first connected, didn't we, on psychosocial factors of shoulder instability. That's when
Yeah,
we first connected.
yeah,
But
yeah.
you've gone on to really start publishing a lot of work on these frozen shoulders. Can we dig into some of this research? Then I saw a paper that investigated patient needs and perspective and clinician beliefs and strategies and whether
Yeah.
they align or not. Can you tell us about that paper? Do
Yeah.
clinicians have similar goals to patients, or are we thinking
Well,
differently?
yes, there are some differences. Frozen shoulder was the line of research of my doctoral research that I ended last October. So
Mm.
I pretty focused on this pathology. I
Yes.
try to understand the status in my country, in Italy. So I organized these two cross-sectional studies, once about the perspective need and expectation of patients suffering from frozen shoulder, and the others about the skill, the management strategies of physiotherapists
Mm.
that manage the subject with frozen shoulder. And I try to understand if they aligned in
Yeah.
this kind of issues. When we try to understand if needs perspective and expectation of patients aligned with management skills and strategies of physiotherapists, we discover that there are some differences. For example, the importance to be reassured is the main team from physiotherapists, but the main target of the intervention asked from patients was, for example, the range of motion improvement and night pain decreasing.
Mm.
So these discrepancies from the main target of the physiotherapist management and the main request of the patients could be an issue in our clinical practice, because the misalignment of expectation could foster in adherence, in decreasing of therapeutic adherence. So this is the first results that bring us to suggest to improve our communication skills and also to work in a shared decision making, assessing the expectation and the need of patients before to organize a therapeutic path.
Yeah, because the patients wanted their night pain to go away and they wanted better movement, and the
Yeah.
therapist thought they wanted reassurance, or
To be reassured for the frozen shoulder, for the benign history, and
yeah,
for the possibility to come back to move freely.
yes,
And but we think it's a problem if there are two targets from the physiotherapist and from the patient. So
yeah. When they
uh,
misalign, we're kind of missing
yeah,
the point, aren't they? The patient.
yeah. That this end in decreasing of therapeutic alliance, and in
Yes,
frustration for the patients that
yes,
understand that the journey
yes,
is not. So another difference is between patients and physiotherapist was about psychological aspects. That is
yes,
the focus of my investigation.
yes,
And we analyzed the mood changes between before frozen shoulder and during frozen shoulder, and we and this results in that the patients become more hungry, more
okay,
frustrated,
yes,
more sad,
yes,
with low mood, and from before to during frozen shoulder. And this, in our opinion, should not be overlooked because
yeah,
we have to face with these mood changes.
yeah,
Moreover, catastrophizing thoughts are really present because patients believes that they can raise the arm as before, that the pain is endless, for
yeah,
example, and also there is a decreasing of perceived social support. And that is
yeah,
also a very important thing. So we also claims to also talk with also the caregiver, with the wife, with the husband, with the
yeah,
family of the patients, because the patients lost his or her role in the family,
yeah,
and also his or her
okay,
role in the work.
yes,
Because for example, the patient can pass from the one that bring the daughters to school to the person that have to be bring to the physiotherapist, for example.
yes,
Uh,
yes.
so the loss of the physical role is a very issue is an issue very important that we have to face with.
Mm.
Also, in the work habits are have to change, and we have to consider it. But for example, the people that work in that are sedentary workers have to face with the lack of concentration from the restless nights,
Yes.
and also, for example, the manual workers have to ask for a changing their role in the work.
Mm.
So if we concentrate only about the shoulder, we lost this.
Yeah.
This scenario, this
Yeah.
landscape. So and a result that we discovered is that effectively frozen shoulder impact cross-sectional in the whole life of the patients.
Yeah. Do you think that's just a specific thing about frozen shoulder? Or do you think it's more, I mean, some of these people have problems for a long time, don't you? Do you think we would, or do you know of any other research that looks for other long-term conditions? Like similarly, you lose your role, you become,
Yeah,
I guess the
yeah.
night pain is specific about the
Yes,
frozen shoulder.
I think that there are some diseases that are quite similar, but frozen shoulder join the pain, severe, often drug resistant, often
Mm,
constant,
mm.
with range of motion limitation.
Yeah,
Uh,
okay.
often other disabilities, other pathology are characterized by just pain.
Yeah,
So,
okay.
but range of motion limitation that hence to disability, to
Yeah.
decreasing quality of life from operational perspective, maybe is quite more invasive, quite more
Mm, mm,
impactful in the
mm.
whole life of the patients.
And so these people, I think what's interesting is I talk to people around the globe about their
Yeah,
frozen shoulder, which we mentioned before offline, didn't we? It's so wonderful. Is then whether your patients get a steroid injection early or not. I understand that therapists in Italy can't refer for a steroid injection,
yeah.
but they are still receiving, somebody is referring for steroid injection early.
Yeah, in
What's the
Italy
process?
we can't administer corticosteroid injection, but we have to refer to a medical doctor.
Yes.
Because, yeah,
And so
but
the
I
patients have had the injection, the patients that you interviewed, they or in
yeah,
this survey,
yes,
they had already
they
had an
had
injection.
not all the sample, but I think the majority they had. And there is a dual perspective in with the clinician relationship, because one perspective is quite positive
Mm,
because the patients climb for injection or for any strategies that will decrease the pain
yeah,
that strongly impact on the function of the arm.
yeah.
And the other negative perspective is that often clinician were perceived are superficial, and they were perceived are patient are people that don't care so much to the world of patients suffering with frozen shoulder, that think only to look at the harm if move more or less. And
Okay.
there are yeah these results come from our meta synthesis with meta summary, and from Crestani and co-authors that
Yeah.
I participate as co-authors, as the last authors. And there is a the result is the dual perspective, the positive and negative one. I
Mm,
think that we as clinicians have to pay attention to how communicate
yeah.
more than what communicate, because maybe the diagnosis of frozen shoulder with the clinical pathology is quite evident, is not so difficult, but it's not difficult for clinician. For
Yes.
patients, is very concerning, because,
Mm,
for example, they pass the 5 months and they go to doctor by doctor for hearing that he has a rotator cuff pathology, calcific
mm,
tendinopathy.
mm.
No, don't worry, it's a
Yeah.
muscle pain, it will pass. And patients perceive the uncertainty of their clinical condition.
Yeah.
So it's okay that it's quite easy to diagnose a frozen shoulder when it's fully explored.
Yeah.
But I think that we as clinicians have to speak with patients, have to ask questions. If we have to answer to all patient questions, even if in our perspective is not so useful, but we have to be empathic with the patients and to take care and support to it.
Yeah. So interesting, isn't it? Because in one hand we have a study that says the patient wants range of movement,
Yeah,
and all the therapist does is give me reassurance. And then now
yeah,
we have another study that says, well, all the physio cared about was that here I am lifting my arm for those people driving in their car. But all they wanted was the range of movement and didn't really care. And so I guess
yeah,
the take-home message is both is important, eh? Both
yeah,
regaining range of movement, addressing the night pain, and
yeah,
being empathetic in that process to
yeah.
understand the massive impact that their problem is having on people.
Yeah, yeah.
Yeah,
The approach should be a comprehensive approach, not limited to a biological side or psychological side, but it should be so a comprehensive, and
yeah. And holistic
I
about
have to take care of whole domains of the whole life of the patient.
Yes, yes. I was just reading this morning through that literature review you did with Kristani, that was the lead author, that you did the systematic review of all the qualitative studies. That's quite an undertaking on
Yeah,
frozen shoulder. It was really fascinating because then we see all the different themes. Do you, I
yeah.
guess, lots of people all over the world now, it seems, are listening to this podcast. Do you think that there are different themes by different locations? Do you see similarities when you review all these themes? What do you think's important?
We reviewed studies from mainly from Europe and from United
Yes.
States. So I think that we can generalize our conclusion in for other contexts, for example, Africa and South of
Yes.
America, as an example. I think
Yes.
that context matters always. So we have to be cautious um, to share our results in other contexts because it
Yeah.
could be quite different. Also, the culture makes difference. Also, the mode with the patients interact with the clinician or with healthcare professional,
Yeah.
and so our results should be contextualized in Europe and North America mostly.
Yeah. So interesting, isn't it? Because that, I mean, the pathology is probably it's the same, we should say,
Yeah,
across the world.
yeah,
People develop frozen shoulder, but the context and the healthcare systems within how that works is different, isn't it? And the cultures
yeah,
are different. And so I guess still you should listen to your patient and still you should address
yeah.
their night pain and their range of movement, eh? Do you have any advice for clinicians across the globe around this? Like, I guess that's what I'm learning from you. Is there anything that you think that transcends from your work that is appropriate for people, not only therapists in Italy, but also therapists across the globe? What do you think is
But
important?
the most important things that I want to share with you is that the frozen shoulder should not be regarded as a self-limiting condition
Mm.
and also require the multidisciplinary path of care. This is for me the most important results from my studies, my investigation, because the approach should be patient-centered, because the results and the consequence that frozen shoulder could give to our patients is always different based on the patient that is unique.
Yes.
So I think that we always do something to decrease pain and something to increase the range of motion, but how we do this and the modalities and the approaches and the empathy should be always different and regarding the subject that we have on our therapeutic study on our private practice.
Yeah.
So maybe the poorly understood pathophysiology of frozen shoulder could contribute to the lack of clear information for patients sometimes,
Yeah.
or the lack of prompt diagnostic or prompt diagnosis. And so I think that we have to face with all these difficulties.
Yeah. It was
However,
interesting. We spoke with Michel Martins a few weeks ago, and really he was saying to diagnose a frozen shoulder, you have to wait until people start to lose their range of movement,
yeah,
by which stage they've already had this incredible pain that has not actually then been diagnosed. So that probably contributes
yeah,
as well, would you say?
yeah,
Yeah. Um, you've let's talk then around the psychological impact of frozen shoulder and what
yeah,
you know around in that space. Tell it maybe firstly tell us about your PhD. You did some systematic reviews as part of that. You then did a cross-sectional study. That's
yeah. My
yeah.
PhD is so it's finished. I won't say that I probably I would do all the investigation also without a PhD course,
Yes.
because I am very thrilled to investigate. I am very thrilled to understand more than of this pathology. So the PhD was a further motivation, but
Yes.
the real motivation is my will to discover, my will to discuss with other colleagues and to understand more and more of this pathology.
Yes.
I work with my patients, so I think it's important to commit in assessing and in investigating the more, because we don't know so much about frozen shoulder. So
Yeah.
we know more than from Codman in 1934
Yes.
said difficult to treat, difficult to explain. Okay, but so we don't so much more, but we don't know that the best treatment. For example, we practice with the corticosteroid injection and manual therapy, exercise and stretching is okay. But we also know that at 2, 5, 7 year follow up, some patients also ask for further treatment because complain of pain and range of motion limitation.
Yeah.
So maybe we have to investigate more and more to understand the really best choice for these patients, and only also to understand the best choice to take care of the whole person and not only
Yes.
of the shoulder,
Yeah.
so this is my motivation that
Yeah.
uh, I think push me also now that I finished my PhD.
Yeah, it's
So
wonderful motivation, eh? And it really helps because it's such a lengthy
yeah,
journey that it helps that you're passionate about it. Tell us about the prospective study that you did. I understand there were some systematic reviews, you did a cross-sectional study, but there was also a
yeah.
prospective study. Tell us about that.
Yes. We in our meetings that we do timely. We organized three prospective papers. One
Yeah.
is yet published. The other is head of print, and the other one is in process.
Okay.
The first one that was published is about the prognostic value of symptom duration, affected arm, and comorbidities, fear of movement
Yes.
for pain, disability, and quality of life patients.
Yes.
And we found that the baseline disability is prognostic for the 3 month baseline of after conservative treatment. And also we found that kinesiophobia is a prognostic variable for the disability of the shoulder region at 3 month disability. So the idea that resulted from these studies that not only biological and not only baseline disability are prognostic, but also modifiable factors that as such as kinesiophobia.
Yeah.
And this is important in my opinion because this open a window about the interdisciplinary treatment of patients with frozen shoulder, because we also have some strategies to treat the fear, to treat catastrophizing. Okay,
Yes.
uh, but I think that. In some patients where when we had a very high level of fear, a very high level of catastrophizing, maybe physiotherapists are not the best practitioner that for treat these patients. So I think that a psychologist will should be a referring figure, a referring professional for share some patients with some particular characteristics about
Mm. And you would
psychological
say
impact.
high catastrophizing and high kinesiophobia that
Yeah,
therapists should refer on. What do you
yeah.
think therapists can do for people with moderate levels of kinesiophobia in a patient with frozen shoulder? I hear that kinesiophobia is predictive of function or quality of life at 3 months? What did you say?
Kinesiophobia is from shoulder disability.
Yeah, okay. So that it really affects then the level of disability they have. What
Yeah.
should therapists do then for people with moderate levels of kinesiophobia? You have any advice for?
Yeah, the only the cross-sectional treatment for frozen shoulder, most important in my opinion, is education about pathology and about
Mm,
the therapeutic path.
yes,
Education increase compliance, increase adherence to also to home exercise and also therapeutic adherence, and education could increase proactive engage of the patients
yeah,
during the therapeutic path.
yeah,
Education also prevent to develop kinesiophobia and prevent to develop catastrophizing sometimes. But when patients is kinesiophobic, maybe we could act with accept as a committed therapy with as cognitive behavioral therapy with some educational strategies to try to decrease
yeah,
this trait.
yeah.
Okay, so physiotherapist, in my opinion, had some weapons for against the
Yes,
kinesiophobia or against the other
yes,
psychological treat.
yes,
But sometimes we have to refer. It's quite obvious sometimes to refer to AD or to orthopedist or to physiatrists. We often do this, especially in my context in south of Italy. It's not quite easy to refer to psychologists because
yeah,
people could become skeptics about their condition and the clinician perspective. So they could they could believe that a clinician can't support and can't believe the problem in its the intensity of the pain, for example.
yeah.
So it's not quite easy. We have to be skilled in communication. We have to be
Yes.
skilled and to be empathetic and to propose this choice.
And you
So
found that kinesiophobia predicted disability at 3 months, but you did you followed them for longer, or you just followed them for the 3 months?
we organized these studies for 3 months because literature suggests that at 3 months, 3 4 months, we had the most important improvement in frozen shoulder
Yes,
subjects.
yes, okay.
So we stopped here, and but it could be a call to action because I think that some variables could be important also for long-term follow-up,
Yes.
and we could understand also such variables that could be impactful for the nowhere responding patients. So the
Mm.
patients that continue to complain pain and
Ah.
disability long term.
Yeah, we don't,
Uh,
maybe some of those variables would
yeah,
predict who those people are, is what you're saying.
yeah,
Yeah.
yeah,
Yeah, yeah. Well, there's lots of work there left for you.
yes, yeah.
You have
And
some other findings, don't you, if you wanted to share around the predictive variables?
yeah,
Yeah.
yeah, yeah. We organized also another prospective studies about other variables that could be of interest in our opinion, and are not biological variables, but
Mm.
are catastrophizing and central sensitization, fair avoidance belief, the anxiety, and quality and quantity of sleep. We
Okay.
assessed these variables, and but we did a particular investigation about anxiety because
Yeah.
we divided the trite anxiety and state anxiety.
And how did you, can
Um,
I just ask how you did that? I'm just interested. The difference between, maybe can you explain to people the difference between state and trait anxiety so that people, those so that
Yeah,
helps
yeah,
understand.
we do this. We do this because in psychological culture, it's important to divide a trait entity,
Yes,
as I say, a dispositional characteristics and not a transient emotional response to the condition. Okay,
yes,
so a particular a particular characteristic of personality of the
Yes.
patients. And it's important to be distinguished by state anxiety, and that is an emotional burden and a consequence of a condition. In our
Yes.
example, in our studies, frozen shoulder.
Yeah.
So we try to divide it to investigate these two types of personality.
Yeah.
And
And
we
how
found,
did you do that though? You used a specific tool. What was the
yeah,
measure? What measure
yeah,
did you
yeah.
use?
We used the STAI, Tried and Anxiety Score.
Ah,
That is
yes. Yes,
a
yes, yes.
psychological patient-reported outcome measure
Yeah.
of 40 questions,
Yeah.
20 for the Tried anxiety and 20 for the STAI anxiety, that
Yes.
help us to understand about the two different types of anxiety.
Yeah. And what
And
can you tell us about
without
that?
what?
What's the answer? What is that important? The difference between state and
Yeah, it's important because we analyze these variables regarding the pain and disability outcome at 3 month follow-up following a
Mhm.
conservative treatment. And we understand that the tried anxiety resulted as a prognostic factor for pain,
Yeah.
while the slight anxiety resulted as a prognostic factor for disability. And
Right.
we also performed a outlier analysis, so to investigate the presence of influential observation. And
Mm.
regarding the Spady pain subscale, this type of sensitivity analysis, excluding outliers, show that known variables remain statistically significant. So
Mm.
the slight right anxiety lose is significance, and
Yes.
probably because when pain is concerned, it's possible that the prognostic effect is reflect the atypical case. So the individuals that show the higher level of tried anxiety, and this further suggests us that the patient with a high presentation of anxiety probably is best to be referred to
Yeah.
psychologists for
Let me
managing
just
this.
recap so I am sure I understand. People who have
Yeah,
state anxiety, that is, they have anxiety
the
before,
tritons.
yeah, okay, so trait anxiety, people who have anxiety as a result of their frozen shoulder were more likely to have worse pain. Is that correct?
No, okay. People that are investigated as a high trait anxiety.
Yes,
Okay.
the one as a consequence of their frozen
No,
shoulder.
no, no. The dispositional characters.
Okay.
Okay,
Okay.
the dispositional characters impact as a factor statistically significant with the pain at three
Okay,
months
so
follow-up.
so just so everybody is clear, trait anxiety is something that they had before the frozen shoulder.
Yeah,
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 and that
because
will,
it's a personality character.
yes, okay, a personality versus state anxiety that is
Yeah.
in that state as a result of the frozen shoulder.
It's a reactive phenomenon, consequence of frozen shoulder.
Yes, okay. And so
Yeah.
now people who have the anxiety before the frozen shoulder is predictive of the
Of pain at 3 months, but only that individuals that have high degrees of anxiety in this
okay.
are predicted. So, in my
Okay.
opinion, physiotherapists that want to improve the patient
Yeah.
condition, these type of patients have to be referred to the psychologist,
Yes.
because we can't act against a
No.
personality character.
Yes,
So
yes, I
this
understand.
this could be interesting for
Mm.
interdisciplinary way to
Yeah.
assist the patients.
The people
Contrary,
who, sorry, let me just recap that. The people who then have anxiety as a result of the frozen shoulder, they were also predictive of something.
yeah, yes, the state anxiety is predicted disability a 3-month follow-up. And also, after the outlier analysis, the state anxiety remains predictive. So maybe this suggests us to focus also outside of the shoulder, and to also suggest for a comprehensive treatment. For example, a strong importance to education, and for example, stress reduction technique. For example, such a specific activities such as yoga that could reduce this situational anxiety. The
Incredible
other
work,
question,
isn't it? It's
yeah,
really amazing the
yeah,
work
yeah,
you have done there. It's wonderful. It's just so important as we learn so much
yeah.
more about that. Yeah, congratulations. It's really neat
Yeah, it's
finding.
a spoiler. It's a spoiler for your podcast
Oh, spoiler.
because it's ahead of print. Yeah, yeah,
Yeah,
yeah.
that's wonderful.
Yes,
That's
I think it's important because it has a great impact of the treatment of the
yeah,
patient. So it can suggest some conduct and some different strategies to take care of the patients.
yeah,
But the other question that we did is, because we know about also the context, is how often do we actually assess these psychological variables and this type of psychological variables?
yes,
Because if these factors are so important, we have to know, we have to
yes,
properly assess, and we
yes,
have to act for improving it.
yes,
And how many opportunities to modulate our
yes.
patients' outcomes we lose by overlooking these variables.
But
Also,
it's a long questionnaire, isn't it? Like
yeah.
40 questions, 20. There is a short for clinicians. There's a shorter version that people could use, or 40 questions to understand state versus trait. And I
Yes, but
understand you don't want people to learn.
we have recruited 80 subjects, and
Yes.
the booklet of questions was not a concern, because we asked it also for the feasibility of the completion, and no, nobody says
Nobody
that it was
minded.
so long. No, it wasn't. No. So we have the completion rate of 100%. So
Yeah, okay.
no missing answers were reported.
Yeah, okay. Is there anything else that you think clinicians, like from these studies around the prognostic variables, that you think is important that you wanted to share with clinicians?
But I think that we have to monitor all variable of the patients for because we treat the patients. But
Yeah.
if we comprehensively know such variables that have an impact on our results of rehabilitation.
Mm,
So it's important. It's
yes.
important because we quite always assess diagnostic variables
Yes.
that are important, okay, but prognostic ones have the possibility to impact our treatment, our results,
Yeah.
and the quality of life of patients.
Yeah.
So maybe are with the same importance, okay.
Yeah.
So
Yeah. Yeah.
maybe research have to increase the knowledge about predisposing factor for frozen shoulder.
Mm,
For
mm,
example,
mm.
how what I have to collect in my medical history for distinguish a patient with a non-concerning painful shoulder
Yeah.
from that one that has a painful shoulder, but it will be a stiff and painful shoulder. So
Yeah.
this is a great for example, a great question that probably uh, we will commit to for answer.
Yeah.
But also for example, the power of imaging in frozen shoulder is not so strong, because we know that radiography serves to rule out, for example, other pathology that could mimic frozen
Mm.
shoulder clinical presentation. And we know that magnetic resonance imaging is not useful if routinely administered for this type of patients.
Yes.
But we published 2-3 months ago a paper that try to analyze the imaging from magnetic resonance imaging, and not by the eye of a radiologist, the human eye, but through AI,
Okay.
through by radiomics. Radiomics is the possibility to extrapolate some data from imaging. So
Hmm.
it's not the tendon, the glenoid, the humerus, but a series of zero and ones that are infinite, and
Yeah.
we understand that some feature extracted by radiomics from the imaging could assess the disability at baseline, and also could predict a disability at 3 month follow-up, because
Okay.
there are some feature that are the feature as are the I learned this
Yes.
through my doctoral research. The feature as are the blank, the gray, and the tonality of gray, one
Okay.
each, one near the other. So
Yeah.
this is a feature
It's
that the
fascinating.
human, yeah, it's a very interesting, because I have to co-work with informatics,
Yes.
and it's a great word. It's a great
Yeah.
word. So I have to learn how to start with the software, how to
Yes.
insert the imaging. So it's very
Yeah.
intriguing.
And that is something that clinicians could do now, or we need more research on that, or it's not really available to use clinically, it's just from research.
No, no, it could be used clinically, because the software is free,
Yes.
and maybe this is only a pilot study, because we recruited 52 subjects, so
Yes.
our results could be only valid in our sample. But we are planning to improve these studies and to try to generalize our findings. So
Yeah.
maybe also the impact, the importance of imaging will be different in the future, because with the AI
Yes.
we could have new possibilities to of interpretation of the
Yeah.
imaging, so new possibility to understand the therapeutic path, therapeutic
Yeah.
flow of the patients,
Isn't
for
that
example.
fascinating? Isn't that
Yeah, yeah,
fascinating? Fabrizio,
yeah.
we need to wrap this up. What do you think? What's your take-home message for clinicians? What do you want them to know about your work? It's fascinating the work that you're doing. And I'm loving your passion for frozen shoulder. Tell what do you want clinicians to know?
Ma clinician, what do you know? But as I said, I am a clinician on law and on research, so I try to join the clinic, and try to join the patient treatment, and try to join the research.
Yes,
I suggest to try, because a researcher alone could not be the best professional for treating patients, and the opposite. So
yes,
to join both the dimension could be the best possibility to assist our patients.
yes.
I am more a clinician than a researcher, to be honest.
That's
Because I
okay, me
love,
too.
yeah, yeah, because I love to stay with the patients. I like to talk. I like to assist. I like to take care of them. Okay,
Yes,
so I am always in my private practice,
yes,
and so. Uh, and this is the message. The message is to be an informed clinician. The message is
yes,
to learn about the research methodology, to be able to criticize the studies, and to found their answers to our questions alone
mm,
through literature, and also to apply evidence-based research to our patients.
yeah,
In my opinion, this is the best way to take care of our patients.
yeah. I think that's a wonderful message. Thank you very much for your time.
No, you're welcome. It's a very pleasure and honor to stay with you this evening.
Yeah, thank you.
And thanks again to Flawless Motion for supporting this episode. So if you want to know more about the shoulder braces or other clinician resources, then head to flawlessmotion.com or flawlessmotion.co.uk for more information. Thanks for listening. I hope you enjoyed the podcast and found some clinically useful tips for your patients in clinic. Please subscribe to the podcast and follow me on social media to keep across the latest releases of the podcast. Don't forget, if you need a shoulder brace for your patients, then check out our shoulder braces at flawlessmotion.com. And if you want to know more about assessment and treatment of rehabilitation of your patients, then check out the online shoulder courses at margieolds.com. Otherwise, take care, enjoy, and see you next time. Please remember that this podcast is for educational purposes for clinicians only and does not constitute medical advice. Please consult with a qualified health professional or contact me to book an appointment for individual assessment and treatment. Cheers.